It's great to be back in Canada. I was just coming from Australia, Great Barrier Reef. Beautiful place there, Daydream Island, you know. Everyone knows me, I'm a pretty lazy person. This is the way I like to spend most of my time. But we're here, we're going to talk about comprehensive TMD. Well, you heard all the smart people today, okay? So now it's my job to put this together and say, what did all these smart people say? And how can we put that into practice, for most of us, general practice, and establish protocols that are reproducible, because that's why you're here. What is the application, what is the practicality of this in the general dentistry practice, or just dentistry? Because we should be amazed by that. And I'm so pleased to be able to be part of this first symposium, of which I know there'll be many, many more. And I have to say that everyone on the board has just done a tremendous job. Dennis and Richard and Dave and everybody that's been involved in the process. Terrific job. Just very, very, very. Because we might not think these things are very important, but they are. Because take a look at every publication that you walk past, and you'll see that so many of us are suffering from, 1 in 5 they suspect having these chronic pain issues. And what does that got to do with dentistry? Well, I think, I think it's already been put out that headaches are under our purview. Here's published from the book, The Headaches by Dr. Olmos. But you got to have some basic understanding of what is your philosophy and how do you go about it. And this diagram by David Walther, just makes the most sense to me. Evaluate structure. The better structure, the less inflammation, the better orthopedic movement, the better you're able to handle the chemical stresses of the environment that we have that's being contaminated on a daily basis, and the mental stresses of life. So that you can handle something like this when a little kid walks in your door, or carried in your door, on IV, and you bring her back to life and send her out to have a good life, as in this person's case. And here's my thought process that's evolved from this, is that whatever you're measuring from, you assume it's absolute. And she made another point. Remember those patients that you put in and they have one ear higher than the other? What does that tell you about their temporal bones? What are you measuring from here? The temporal bone. Well, do you think everybody's temporal bones are exactly parallel to each other? They can't be divergent or twisted? Maybe that's why those ear rods don't go in. So if you're measuring from divergent temporal bones and trying to get a mandible, maybe it's symmetrical, but how's it going to match up in that relationship? That isn't the basis for my evaluation anymore. My determination of where things should be. Because that would assume that all temporal bones are spatially correct. And it's just the mandible that's out. And that's not true. Now that I have a CT scan, and now when you go into imaging, they talk about 3D positioning, and now I've really evolved in my thinking. I've come a long way to understanding, and now imaging and technology has caught up to what I've been saying for a while. And my evaluation of structures and all the other things that we should be looking for, like Doc was saying. Well, I kept seeing people walk in like this, and after I removed their inflammation, they were like this. Huh. So we wrote a paper on that in 2005, where we took 51 patients, 13 to 74 years of age, decompressed, and then measured. And we found that there was a 4.43-inch return of head posture on average with these people when you got rid of the inflammation. Didn't matter how young or how old. Didn't matter what the pathology was. You know the common denominator? Inflammation.